And I'm going to be introducing Dr. Brittany White today. She completed her Doctor of Pharmacy degree at the University of Tennessee Health Sciences in 2012 and completed a residency in clinical pharmacy practice at Blount Memorial Hospital in Maryville, and that was in 2013. She's a board-certified pharmacotherapy specialist and has practiced with the Erlanger Clinical Pharmacy Department for 5 years. With focused efforts in anticoagulation management as a member of the Pharmacy Anticoagulation Service. She also serves as an educator for the pharmacy residents and medicine residents on medicine teams. And it's always great to have her on the team, and she contributes a lot to our patient care. So welcome, Brittany White.
Thank you so much, and thank you everyone for being here this morning. I'm going to talk about peri-procedural management of anticoagulants to look at standards of practice and updates on this topic. Before I begin, I have to let you know that I don't have any financial conflicts of interest. And throughout the presentation, we're going to focus primarily on management of oral anticoagulants, primarily around elective procedures with some discussion on urgent reversal of anticoagulants. We'll develop an evidence-based plan for perioperative bridging and assess indications for bridging by assessing patient and procedure bleeding and thrombotic risks. And then finally to look at recommendations for when to resume these medications after a procedure. So this is a timely and important topic. It's been shown in the literature that 1 in 10 patients who present for a surgical procedure will require interruption of anticoagulation, most commonly when used for stroke prophylaxis or for patients with mechanical heart valves. And we know that this can be a complex process to develop a perioperative plan for management of these drugs, primarily because of the difficulties in characterizing risks associated with the procedure in the patient, and especially if you consider the changing landscape of oral anticoagulation. We have many new direct oral anticoagulants available to us with different pharmacokinetic properties. And evidence has shown us that there are potential for gaps in care while we're communicating such plans among often multiple providers in both the inpatient and outpatient settings, as well as to the patient. And so we have to make sure this communication is thorough and based on evidence to ensure optimal bleeding and thrombotic outcomes. In 2016, the American College of Cardiology formed an anticoagulation initiative work group. And the aim of this group was to improve the overall delivery of anticoagulant care, primarily by assessing current practice patterns in management of anticoagulation around surgical procedures. So this was a survey that was disseminated to more than 12,000 physicians who manage anticoagulation in their everyday practice. And some of the things that they looked at were, 1, how should we be assessing thrombotic risks for the patient? And 2, when should we be providing parenteral heparin products for patients who require interruption of therapies? And so the survey results indicated that while most providers across different specialties, and this was including cardiologists, primary care physicians, gastroenterologists, and orthopedists, we all agreed on how to assess and determine the thrombotic risk of the patient by presence of mechanical heart valves or an increasing CHADS VAS score. But there are very significant differences as to when various specialists felt that parenteral anticoagulants for bridging were indicated during interruption of oral therapies. And in light of the increasing amounts of evidence and documented disagreements between specialties with these high-risk medications, this year the Joint Commission designated this topic as a national patient safety goal, which means that any facility that's accredited by this organization is now required to develop evidence-based practice guidelines for their institution on perioperative management of all oral anticoagulants. And that can be a very difficult process because there are a lot of conflicting studies and so far very low quality evidence to support the recommendations that we have. Since the publication of the College of Chest Physician Guidelines on Perioperative Antithrombotic Management in 2012, 5 different organizations have released their own recommendations on management of anticoagulation around surgery, and this is primarily based on large observational studies such as the ORBIT-AF trial and the PAUSE study, with very few randomized controlled studies to support these recommendations. And so you can understand why it might be a little confusing depending on which guidelines you may be reviewing to determine what is the optimal plan for your patient. So as we go through this presentation, I'm going to review 4 key questions that should guide the clinician through management of anticoagulation to result in optimal bleeding and thrombotic outcomes. And the first of those is, should anticoagulation be stopped for the procedure in the first place? This could be a difficult problem to assess because you have to determine the procedural bleeding risk, which can be quite difficult, and we'll look at why in just a moment, as well as observe the unique patient characteristics that may increase their bleeding risk, and balance these in order to determine what the most appropriate route of anticoagulation will be. Do we hold the anticoagulant completely, or is there an acceptable small level of anticoagulation during the procedure? Not all procedures will require interruption of anticoagulation. Evidence has shown us that those procedures that are associated with a minimal risk of bleeding result in better outcomes when anticoagulation is continued rather than held. And examples of those with minimal risk would be minor dermatologic procedures, dental extractions, or cataract surgery. And from the bruise control and compare trials, we even saw that continuing anticoagulation, particularly vitamin K antagonists, during certain cardiac procedures such as ablation of atrial fibrillation and cardiac device implantation also resulted in better bleeding outcomes. But there is no stratified risk scoring tool to determine the risk of bleeding around a procedure. And so we fall to guideline recommendations that are based primarily on low quality data and case series studies. So the most important thing we can remember when trying to determine the category of bleeding risk for a given procedure is that the opinion and experience and preference of the proceduralist is going to mean the most. In general, low-risk procedures listed there on the left-hand column are those that are associated with a less than 2% rate of major bleeding within 48 hours after the procedure. And then high-risk procedures will be those that are associated with at least a 4% or more increased risk of bleeding after the procedure. And so examples of those would be cardiac procedures and neuraxial procedures, PEG tube placement, for example, or biopsy. So what does this mean for anticoagulation? So for those undergoing procedures with a minimal risk of bleeding, continuation of anticoagulation is recommended. For those undergoing procedures with a low risk of bleeding, major guidelines recommend that a small amount of residual preoperative anticoagulant effect may be acceptable. So recommendations for management of those oral agents would be to hold the drug for at least 2 to 3 half-lives, or for those on vitamin K antagonists, targeting an INR at the lower end of the therapeutic range if possible. And for procedures at the highest risk, we would ensure that there is no residual anticoagulant effect, meaning holding the drug for a full 5 half-lives to ensure negligible drug activity, or an INR less than 1.6 for those on vitamin K antagonists. And so these recommendations focus on patients who do not have a baseline intrinsic increased risk of bleeding. To assess that, this is primarily done using validated bleeding risk scoring tools. So there are many bleeding risk scoring tools available, but the HAS-BLED score has actually shown to be predictive in the perioperative setting so that we can identify potentially modifiable bleeding risk factors prior to surgery. So with the HAS-BLED score, a point is given for each of the factors listed here, and a score of 3 or higher would indicate that that patient would be higher than those of the average population for bleeding post-procedurally. Other risk factors that should be considered, any of these, of course, a prior bleeding event, especially recently within the last 3 months, or if the patient has had bleeding from a similar procedure in the past. And then if patients are receiving concurrent antiplatelet medications or have pre-existing thrombocytopenia, these should be considerations when we're making decisions regarding how long to hold a drug or whether to provide parenteral agents during interruption for bridging, for example. So most procedures are going to result in holding of the anticoagulant for some defined period. And the next question that has to be addressed is, when should the anticoagulant be stopped? And this is where I'm getting into a lot of the information that pharmacists like to discuss, because we have to look at the pharmacokinetics of the drugs. Procedural interruption of warfarin, as we know, is a very well-described process, and not much has changed about the way that we manage warfarin around the time of procedures. Direct oral anticoagulants, though, are more complex. We don't have widely available assays that can help us assess or quantify the amount of anticoagulant activity, and we have to consider then each individual agent's pharmacokinetics, because although these are primarily renally eliminated, they are so to different degrees, depending on the agent that the patient may be taking. And so one thing that we have to know in order to make educated decisions about management of DOACs would be a calculation of the patient's creatinine clearance using the old Cockcroft-Gault formula rather than GFR. So in looking at the oral anticoagulants, just an overview, again, not much has changed with the way we manage warfarin. The emphasis I'm going to place here is on when and how to use vitamin K prior to procedures for patients on a vitamin K antagonist. So for an elective procedure, a non-urgent procedure where time is on our side, the recommendation would still be to hold warfarin for 5 days prior to the surgical procedure. But we should note that that could potentially be longer in patients who have pre-existing hepatic or renal dysfunction, elderly patients who may have a prolonged time to metabolism of the drug. And so for that reason, it's recommended to check an INR at least a day before the procedure, so that if the INR hasn't come down to our desired goal, we can provide some very small amounts of vitamin K for reversal, 1 or up to 2.5 milligrams. For urgent procedures and emergent or life-threatening bleeding scenarios, this is when we would consider using potentially larger doses of vitamin K. However, evidence has shown us that 10 milligrams of vitamin K is not always necessary to completely reverse a patient. Lower doses of vitamin K are often sufficient to reverse INRs to a meaningful pre-procedural goal for those who have INRs that are maybe mildly elevated, so 5 or less. So the degree of elevation in the INR is going to guide you as to how much vitamin K should be provided to reverse that warfarin. Overcorrection is the concern here with providing unnecessarily high doses of vitamin K because of the development of warfarin resistance after the procedure, which can then result in complications resuming the therapy and increased risk of bleeding as warfarin doses are then increased to overcome that vitamin K resistance. So for those undergoing an urgent procedure needing the INR to come down quickly within 24 hours, vitamin K 5 milligrams is often quite sufficient. And this should be given either intravenously or orally. So there is a recommendation to avoid subcutaneous administration of vitamin K. And when you think about the pharmacokinetics of this drug, if you want to ensure that your patient achieves that meaningful reversal, subcutaneous administration of vitamin K is going to result in a very erratic absorption, whereas oral administration of vitamin K is quite reliable. The bioavailability is very high, and it can result in reversal of the drug within 24 hours. Intravenous therapy is going to reverse the INR much faster, so the onset of intravenous vitamin K is going to be much quicker within 2 to 6 hours. But regardless, we should be expecting to see the full effects within 24 hours of the drug. And then finally, for emergent procedures or any life-threatening bleeding, this is where a reversal agent such as PCC or prothrombin complex concentrate comes into play. So when we're reversing this drug with Kcentra, it should also be emphasized that vitamin K must be administered with the Kcentra. And so this was a practice pattern we observed that we weren't always getting right when we recently evaluated our practices with Kcentra for this indication. So Kcentra's half-life is not as long as warfarin, and if we don't also provide vitamin K, we would be at risk of rebound elevation in the INR and potential increased risk for bleeding or rebleeding. And then finally, when bridging, if parenteral anticoagulation is indicated, and we'll look at those indications in a moment, initiation of the heparin product would not be recommended until we've observed that the INR is below the therapeutic range, rather than starting a heparin product once we expect that the INR is lower without truly assessing the lab value. When we talk about direct oral anticoagulants, this is where there's a little more confusion and a lot more updates in the literature as to how these should be managed around the time of a surgical procedure. These all have a very rapid onset of effect. So regardless of the agent that you choose, you're looking at peak anticoagulant effects and therapeutic anticoagulation within 1 to 2 hours of giving the medication. And the half-lives are pretty similar as well. So across the board, generally the half-life is about 12 hours, with rivaroxaban being a little bit on the shorter end of that range, with a half-life of on average about 8 hours. But the differences are primarily in their renal elimination, and that's why these drugs have different recommendations for perioperative holding. So if you look at dabigatran, you can see that it is the most renally eliminated of all the direct oral anticoagulants. And so we'll see that its recommendations for interruption are a little bit different from our 10A inhibitors, rivaroxaban, apixaban, and edoxaban. This is a table that I've abstracted from the American College of Cardiology article that was published in 2017. Prior to this time, we had no consensus guidelines or recommendations for how to systematically interrupt these agents before various procedures. And so what they've done for us here is to stratify based on the risk of bleeding associated with the procedure on the left-hand column, and then along the top you see, depending on the creatinine clearance as calculated by Cockcroft-Gault, how long we should hold these agents before a procedure to ensure minimal anticoagulant effect. So with the 10A inhibitors, so apixaban, rivaroxaban, or edoxaban, for patients who have a creatinine clearance greater than 30, we can hold these agents for 24 hours before any low-risk procedure and feel confident that that patient can be then taken to surgery with minimal bleeding risk. But for creatinine clearance less than 15, and that's including not patients on dialysis, we want to give a little bit more time for those agents to clear. So the recommendation would be a minimum of 36, and I think in practice most would tell you at least 48 hours before that patient can be safely taken to surgery. And we should recognize that especially in patients on dialysis or those with end-stage renal disease, we don't have any sufficient data to guide us about the safety of when to interrupt these agents. And when you look at patients who are undergoing procedures that have a high or unknown bleeding risk, even those with normal renal function should have their 10A inhibitor held for a minimum of 48 hours. And then for patients with end-stage renal disease, again, we don't have sufficient data to make recommendations. And so the recommendation would be to hold that agent for at least 3 days. And the American Society of Hematology even recommends considering a 10A level to sort of estimate or determine if there is significant anticoagulation left in the body. Dabigatran is a little bit different. If you'll remember, it's the most renally eliminated. I won't read out this entire table to you, but to make the point here that based on the procedure and the stratification of the creatinine clearance, dabigatran is going to have to be held for quite a bit longer than the 10A inhibitors because its renal clearance is going to be much slower. So the question that is often posed to me and some of us on the anticoagulation stewardship team is, okay, thank you for the recommendation, but I don't have time to wait that long before the procedure. So are there any labs that I can order to assess the amount of anticoagulation that we have on board? And the simple answer to that is no, not really. If you look at this table, it's defining expected elevations in different coagulation assays based on the different agent. So when we look at dabigatran there, which is our direct thrombin inhibitor, you see that it primarily will result in an elevation of the activated partial thromboplastin time, thrombin time. This is Eckering clotting time. I don't think we have availability of that assay here, but you would not rely on the 10A activity to help you determine if there is sufficient dabigatran activity. This is in contrast to the 10A inhibitors, which are far more likely to prolong the INR, particularly rivaroxaban. And this is not a direct linear correlation to the amount of systemic anticoagulation. An elevated lab parameter can simply indicate that there is significant presence of anticoagulant effect. However, a coag assay within normal limits, for example, would not preclude any systemic anticoagulation. So we're essentially using this to clue us in to be more prepared intraprocedurally to have supportive measures on hand if we must urgently take the patient to a procedure and we do see elevations in these parameters. And so the next question will be, well, how should I handle this patient that's been on a DOAC? I cannot delay the procedure. Should I reverse this patient? So the Institution on Thrombosis and Hemostasis has given us very clear guidelines for when to consider DOAC reversal agents, because these are not necessarily benign. They state that DOAC reversal agents can be considered for patients who are undergoing a procedure with a high bleeding risk when we cannot safely perform the surgery on anticoagulation and we cannot delay that procedure, or if there is demonstration or reasonable expectation for a clinically relevant DOAC level with a high risk of bleeding. They also give us scenarios for when to avoid antidotes for these drugs, and those would include elective surgeries that can be delayed, gastrointestinal bleeding that stops with supportive measures alone, and patients who have excessive anticoagulation but are not bleeding. So this would be, for example, a patient who has ingested toxic levels of a direct oral anticoagulant. Without active bleeding, we would not empirically use reversal agents to prevent or minimize that risk of bleeding. So what does that look like for us here at Erlanger? We have reversal agents for all of the DOACs, but we have to kind of look at the details for how these are working. Dabigatran is effectively reversed with the monoclonal antibody idarucizumab, or brand name Praxbind. This is given as a total of 5 grams intravenously and very rapidly reduces and eliminates the anticoagulant effect of dabigatran. If you compare that to the 10A inhibitors, apixaban, edoxaban, and rivaroxaban, the standard of care for reversal has become the prothrombin complex concentrate, Kcentra. However, this is different from idarucizumab in that it isn't actually reversing the drug. It is rather providing a concentrated amount of clotting factors, and time is really our friend and the only thing we have to ensure clearance of the drug. But there have been changes in recommended dose approaches for Kcentra. Historically, and if you look at some of the older guidelines, 50 units per kilogram IV as a single dose was recommended for life-threatening bleeding associated with these drugs. But newer evidence has shown us that lower fixed-rate doses of 2,000 units can be as effective in achieving hemostasis. And this has been studied with DOACs, and in some of the newer recommendations, you'll actually see a strong recommendation for this approach. For example, the Anticoagulation Forum has gone away from recommending a higher weight-based dose. And so this could potentially result in less exposure to drug, less risk of thrombotic potential from the drug, and lower costs. INR should never impact your dosing approach for Kcentra. INR is only used to calculate dose for patients who require reversal of warfarin. And this was another common misstep that we observed in evaluation of this drug internally recently, which resulted in a modification of our Kcentra order set. And the next thing that we have in our arsenal, which I frequently get questions about, is Andexanet. Do we have it? Does it work? What is it? And One thing to mention for 10A inhibitors also is that dialysis is not effective for these drugs. It would not be expected to effectively remove the medication or decrease the risk of bleeding. So andexanet alpha is a recombinant human factor 10A derivative that was approved by the FDA earlier this year, specifically for reversal of only two agents, rivaroxaban and apixaban. So unlike Kcentra or PCC, this is actually going to bind to the drugs and render them inactive for the duration of the drug. It's given as a one-time bolus dose and then a 2-hour infusion. The dosing scheme is a little complicated, though, because it depends on which agent the patient was anticoagulated with, and also the time since last dose, which we all know is often a problem. The patient can't recall or is unable to tell us. But it does work very quickly. In a single-arm study, it was shown to reduce anti-factor 10A activity by 90%. However, as soon as the infusion was completed, we saw immediate re-elevation of 10A levels within 2 hours of discontinuation. But in terms of its half-life, in that study when they assessed hemostasis at 12 hours after administration, hemostasis was determined to be either good or excellent at 12 hours after the drug was given. So why don't we have this? Why don't most facilities have this? I think you'll be hard-pressed to find that the majority of facilities across the country are bringing Anexa in-house. We do not currently have this on formulary here. And some of the reasons are, firstly, it does not have any comparative outcomes data with Kcentra. And we have seen that Kcentra is effective if you look at the results, for example, from the UPRATE study. And one early study that has not yet been published in a peer-reviewed journal in trauma patients, where they compared Kcentra versus andexanet for reversal of these drugs with bleeding, suggested that those patients who received andexanet may have had increased mortality. It has a black box warning for increased risk of thrombosis. It's quite difficult to compound, resulting in delayed delivery and administration to the patient once you order this drug. And also recent studies have shown us that, as you might expect, it causes resistance to heparin products. And so patients who are going to an emergent procedure, which may require intraprocedural use of heparin, would be required to use an alternative anticoagulant besides heparin. And so that can cause problems if not recognized early by the proceduralist, and used something such as a direct thrombin inhibitor, for example. And it comes with quite an impressive price tag. So depending on the dose that's needed, we can be charging the institution up to $50,000 per dose, when we don't have any indicators that this is any more effective than Kcentra at this time. And I believe there are comparative studies ongoing right now comparing hemostasis with Kcentra and andexanet. Okay, so we've looked at when to stop these agents prior to the procedure. We've seen that we have updated recommendations from major guidelines. The next question is, does the patient require bridging with a parenteral agent before the time of surgery once the anticoagulant is interrupted? And this has been perhaps the major area of research on this topic within the past 5 years. So bridging is a concept that came about for patients who are taking vitamin K antagonists who had to have therapy stopped for a procedure. And there was concern that given the long half-life and the prolonged amount of time we have to hold that medication before a procedure, that we were leaving our patients exposed to increased thrombotic risks. And so the idea is that providing a parenteral agent such as heparin, which has a fast onset and offset, would reduce the thrombotic risk to the patient and improve outcomes. So in looking at the evidence, firstly we see that in patients receiving DOACs, major guidelines suggest that we should not provide parenteral anticoagulation when holding these agents before a procedure. When we might consider parenteral agents when holding direct oral anticoagulants would be for the patient who comes out of surgery and perhaps has a delayed ability to take oral medications. And so in that case, until the patient could receive the DOAC, we would perhaps provide a heparin product during that time. But for other indications, primarily with vitamin K antagonists, you will see that there is mounting evidence that the risks outweigh the benefits with bridging, except for those patients who are at the highest thromboembolic risk. So we first have to look at recommended assessment for evaluating a patient's thrombotic risk. So we divide that into 3 categories, which would be mechanical heart valves, atrial fibrillation, and VTE. When we look at patients with mechanical heart valves, those that would be considered at the highest risk right now are those with mitral valve prosthesis, which is no surprise, older mechanical valves such as caged ball, or those who have had an arterial thromboembolic event in the previous 6 months. Moderate risk then would be those who have a bileaflet aortic valve with another risk factor for stroke, which I've listed there. And then the lowest risk would be those with a single mechanical aortic valve without other stroke risk factors. And we'll see how this comes into play in a moment with the recommendations for bridging. For those with atrial fibrillation, results from the randomized controlled trial, which was the BRIDGE study, have led major guidelines to suggest that bridging should only be considered when the CHADS-VASc score is 7 or more. For patients who have had an arterial thromboembolic event within the last 3 months, or those with rheumatic valvular heart disease, moderate risk would be considered a CHADS-VASc score of 5 to 6, and those at the lowest risk would be those with a CHADS-VASc score of 4 or less. And what about patients who have a high risk for VTE or a history of? We stratify risk here primarily based on the amount of time since the thromboembolic event. So that would be patients who have had a clot within the past 3 months or have a severe thrombophilia, which is defined as antithrombin or protein CNS deficiency, presence of antiphospholipid antibodies, or multiple abnormalities. Moderate risk would be those who have had a clot within the past 3 to 12 months or a non-severe thrombophilia. Interestingly, they list active cancer here or history of a recurrent VTE. And then the lowest risk would be those who have not had an event in the past 12 months and don't have any other chronic risk factors for clots. So, in patients with VTE, the question to bridge or not to bridge, an examination of the guideline recommendations. If you look at the older guidelines that were published in 2012, the CHEST guidelines tell us that for those that are at low to moderate risk of VTE, we should feel comfortable not providing bridge therapy to those patients while interrupting their warfarin. But they kind of leave it up to us to do a very close risk-benefit analysis for those who are at moderate risk. That's in contrast to the ASH guidelines that were released just last year, who suggest that in low to moderate risk, we should feel comfortable not providing bridging and interrupting anticoagulation with a strong recommendation. And then, of course, for those at the highest risk of VTE, bridging is recommended by both groups. When we look at atrial fibrillation guidelines, we see that those at the lowest risk have no indication for bridge therapy, but bridging may be considered once we get into the moderate to high risk categories. For those at moderate risk of stroke, the guidelines say that we likely should not bridge these patients unless there is a history of stroke or TIA in the past. And for those at the highest risk with a CHADS-VASc score of 7 or more, we should be considering bridging, except in those patients who have had intracranial bleeding or major bleeding within the last 3 months. And even at that time, they say consider not providing heparin therapy during interruption of warfarin. So how do we accomplish that? There's a lot of controversy about what dose and regimen of heparin is optimal to prevent stroke, but also minimize the major bleeding risk during the immediate post-procedural period. So the CHEST guidelines actually recommend 3 options for bridging, with the highest emphasis placed on therapeutic or high-dose heparin products. So that would be accomplished with a heparin infusion or therapeutic dose of a low molecular weight heparin product. Major changes in this area would be that there is a much higher emphasis now on preference for a low molecular weight heparin, and this is for several reasons, but primarily because the pharmacokinetics of low molecular weight heparin are much more reliable than that of unfractionated heparin. And a recent internal study did indicate that heparin infusion management is suboptimal at our own facility, with an estimated time in therapeutic range of less than 40%. And so providing a low molecular weight heparin will result in a more predictable level of anticoagulation And we have clear guidelines for how soon to stop these agents before a procedure that should give us confidence that those patients aren't at increased risk of bleeding just because they're on a product that has a longer half-life. But the CHEST guidelines also suggest that there should be a consideration for lower dose regimens. And so they recommend an intermediate dose of Lovenox 40 milligrams every 12 hours, or even low doses, which would be prophylactic regimens. And they don't really give us a lot of guidance on when we should use those low doses, except to say that in patients who are at the highest risk of bleeding, who require, or it's felt strongly that they have a high thrombotic risk and some amount of parenteral anticoagulant would be beneficial, that we might consider those lower dose regimens. Prior to surgery, heparin products should be held at least 4 to 6 hours before the surgery with consideration of the PTT. And then for low molecular weight products, CHEST guidelines tell us that we should hold these 24 hours before the procedure, regardless of the procedural bleeding risk, which is a little bit different because it used to be 12 to 24 hours depending on the bleeding risk of the procedure. So now, kind of rounding out the presentation here, we're going to look a little bit at the most recent evidence supporting differences in bridging practices. In atrial fibrillation, it is very common knowledge now that the risk of bleeding associated with bridging does not outweigh the risk of thrombosis for patients who have the lowest risk of stroke. So this concept really began to emerge with confidence in an article that was published by Siegel and colleagues in 2012, where they looked at a meta-analysis of 34 studies and found that the risk of bleeding outweighed any benefit in reduction of thromboembolic events in AFib patients at low to moderate risk of stroke. And then those findings were echoed in the ORBIT-AF trial, which was conducted in 2014, where we looked at a large number of patients who were bridged and compared them with those who were not, and saw a twofold increase in bleeding risk with no reduction in thrombotic events for those who were bridged. And then finally, the bridge trial results, which were our first randomized controlled trial in this population, corroborated this evidence, showing that patients who have a low to moderate risk of stroke did not benefit from parenteral heparin agents around the time of surgery. So we know that this is the case with patients on vitamin K antagonists, and that there is a lower impetus to bridge these patients. So what does that mean for patients on direct oral anticoagulants? I showed you earlier a table that was released from the American College of Cardiology, which stratified a procedure based on, stratified the anticoagulation approach based on the procedure risk and the creatinine clearance. But last year there was a study conducted by Duquetis and colleagues called the PAUSE study, and they were aiming to simplify the approach to management of DOACs around the time of surgical procedures. And so they looked at patients who had atrial fibrillation managed with a DOAC and had normal renal function defined as a creatinine clearance greater than 30. And they looked at a standardized management plan for these patients. They wanted to establish one standardized procedure for management of direct oral anticoagulants that could simplify the approach and give providers confidence. So they looked at major bleeding and arterial thromboembolism at 30 days. And then secondarily, they looked at what level of anticoagulation was really achieved by holding these direct oral anticoagulants with this approach. And that's really interesting, and these results were not available to the investigators until after the study. So what they did was, for patients who were undergoing procedures that were considered to have a low risk of bleeding, they stopped the direct oral anticoagulant the day before the procedure. If the procedure was considered to be high risk, they stopped it 2 days before the procedure. And at the discretion of the clinician, dabigatran could be stopped a little bit sooner for patients who had a creatinine clearance less than 50, recognizing that it is much more renally eliminated and might need additional time to be cleared in those who had some degree of renal insufficiency. And then after the procedure, they resumed these drugs in accordance with recommendations from the American College of Surgeons. When you look at the results of this study, we see that there was no difference in thromboembolic events between the groups, and there were very low rates of major bleeding. So the investigators hoped to have a less than 1% rate of major bleeding, but designed the study to detect a less than 2% rate of major bleeding, which they accomplished. And most importantly, they had hoped to see a residual anticoagulant effect of less than 50 nanograms per milliliter. So negligible DOAC effect would be anywhere from 25 to 50 nanograms per milliliter. And what's really important to note here is that almost 95% of patients in each group had appropriate levels of direct oral anticoagulant before the time of the procedure. So the conclusions from these authors were that we now have a standardized management approach to patients on direct oral anticoagulants who have normal renal function, which would be defined as a creatinine clearance greater than 30. And they also showed that obtaining specific coagulation studies before a procedure is not necessary, and suggested that periprocedural bridging, so use of a heparin product once the DOAC has been held, is not necessary. So in general, for patients with atrial fibrillation, the message is those who have a low to moderate thromboembolic risk probably should not receive parenteral heparin products while holding their oral anticoagulant. We have now defined a standard perioperative approach based on the results of the PAUSE study. But some things that remain to be seen are, for those patients who are at the highest risk of thrombosis, what is that true thromboembolic risk during the period of interruption of therapy? What is the optimal dose of heparin in those who do require bridging? And in patients who have significant renal impairment, what is the ideal strategy for interruption of DOACs? Now we'll take a look at those who are considered very risky, those who have mechanical heart valves or a history of venous thromboembolism. The main message as we go through this information will be that we have a paucity of randomized controlled trials contributing to trustworthy data. We have low-quality studies that evaluate quite heterogeneous groups of patients with mechanical heart valves and history of venous thromboembolism. We don't have a great strategy for what is the optimal dose of heparin, but you'll see that as with studies in patients with atrial fibrillation, we continue to identify unacceptable bleeding rates in those who are bridged, and that recent studies that I'll show you are challenging the practice of bridging patients who are high risk. This study is the first systematic analysis to evaluate information on comparing bleeding rates and thromboembolic rates in patients who are on secondary prophylaxis for VTE, who require interruption of therapy for surgery. So these investigators evaluated 28 studies. They were non-randomized. Again, the pre-existing data is very low quality, but 19 of these were prospective studies. And they looked at patients who were on a vitamin K antagonist who had already had a VTE in the past. And some of the patients in these populations did have mechanical heart valves and atrial fibrillation. But before we look at the results, we have to know some of the confounders. The bridging strategies were quite variable among assessed groups, often based on the provider's opinion of the thromboembolic risk. Sometimes all patients received bridging, some did not. But in the assessed groups, the majority of these patients were receiving their bridge therapy both before and after the procedure, which is important to note. So we can't really define comparative estimates between groups because of the nature and design of the study. But what we can look at is the pooled incidence of events. So when we look in the main analysis of patients, comparing patients with bridging and without bridging, we see a very low overall thromboembolic event rate of 0.5 to 0.7%. And then that maintains in the sensitivity analyses and the subgroup analyses when they tried to stratify varying thromboembolic risks and low molecular weight heparin doses. Contrast that with major bleeding events. So across groups, we see a pooled incidence of 3 times the risk of bleeding in bridged patients compared to those who were not. And when we look at any bleeding, the rates go up even higher, as you might expect. So the conclusions of these authors were that they saw an increased risk of bleeding without reduction in thromboembolic events. And they suggested that for patients with low to moderate risk of VTE, periprocedural heparin products are overused. but did, of course, identify that high-quality studies are still needed to confirm these results. We'll talk about some new studies in patients who have mechanical heart valves, but first we have to look at how we define the risks associated with those valves. And there is, each recommendation from the major guidelines is a little bit incongruent. So if we look at low-risk valves, the AHA and the ACC define bridging practice as temporary interruption of VKA without need for bridging. So a low-risk valve would be, of course, an aortic mechanical valve, for example, without additional risk factors for stroke. The CHEST guidelines suggest temporary interruption of VKA without bridging for low-risk valves. If you look at high-risk valves, there has been a change to the recommendations provided by AHA and ACC. For those with high-risk valves, so mitral or double valves, temporary interruption with bridging is reasonable, but they do not provide a dose recommendation, and this was a lowered level of recommendation with the 2017 update. The CHEST guidelines suggest that in patients who have high risk or high-risk valve, bridging is suggested, and they give a preference to therapeutic dosing, but also suggest other dosing regimens. And the European Society of Cardiology sort of disagrees with everyone and says that regardless of the risk of the valve, that temporary interruption with bridging is recommended with a grade 1C recommendation. So one trial that may change the paradigm on this approach will be the results of the PERIOP-2 trial. So the results of this study were presented at the recent National ASH meeting, have not been released in a peer-reviewed journal at this time, but the investigators conducted the first randomized controlled trial in patients considered high risk for thromboembolism. So those were patients with AFib or a mechanical heart valve who were on warfarin and were going to have that therapy interrupted for a non-cardiac surgery. And the major question was, are there differences in safety and efficacy between those high-risk groups when we provide bridging versus when we do not? So they looked at major thromboembolism and bleeding at 90 days. And of course, secondary outcomes were major bleeding and overall survival. Before you look at the results of this study, it's very important to note who they did not include. Those would be patients with pre-existing significant renal impairment, those who had a mechanical valve but had had a prior arterial thromboembolic event, patients who had multiple mechanical valves, or those older, more risky valves such as Starr-Edwards, and cardiac and neurosurgery, because we know that those are already associated with increased rates of major bleeding. So the authors used dalteparin, which is another low molecular weight heparin. And the very interesting thing about this study is that they divided patients into two groups. One group got low-dose dalteparin, and one group got high-dose dalteparin. So patients that were undergoing a procedure that was associated with a low risk